Alrighty, this is chapter 2 in your Traeger textbook of radiographic positioning. This is the second half of lecture from chapter 2, and this is on specialty views of the chest. So these will actually begin on page 96. We've already gone through all of the anatomy and the systems that are found in the chest. So this picks up with some specialty views that you can do in addition to the routine views. The reason these are called or considered specialty views typically is because the patient has already had a routine chest x-ray taken and a radiologist has read those images, and based on their findings, typically they will request one or more additional views or specialty views, meaning that whatever they're seeing in that routine PA and left lateral chest, it is likely that they want to further evaluate or investigate what is going on, and they could order some of these specialty views. The specialty views that we're going to look at, we could look at an AP supine chest, an AP semi-erect chest, a lateral decubitus, and that could be either a left lateral decubitus or a right lateral decubitus, a lordotic chest x-ray, and also oblique views, either AOs, which are anterior obliques, or POs, which are posterior obliques. So let's look at some of these. We'll start off on page 96. You can see that the picture on the left is an AP supine chest, and the one on the right is actually considered an AP semi-erect chest. And the central ray on both of these, actually with all chest images, the central ray is always to the thoracic level of T7. Even with the PA, the left lateral, the central ray on chest x-ray is always to the level of T7, and they reference that with either the supine or the semi-erect, you have to make sure that you are perpendicular to the sternum, meaning that your central ray is perpendicular to the sternum. So in this picture on the left, with the patient lying flat, that's not so hard to do, only because the central ray would be coming straight down and that would be perpendicular. And I'm not sure if you can read those words, but that says only as a last resort, meaning this is not ideal. Remember, we talked about one of the main reasons we try to do chest x-rays erect or upright is so that gravity aids, allowing everything to fall to its lowest level. It doesn't show engorgement of the veins and the vessels, and it allows the anatomy to fall and show air fluid levels. So when the patient is supine like this, you're really not going to evaluate air fluid levels, and a lot of times the lungs will not expand as deep because gravity is actually kind of fighting against you with the patient supine. But there are times that we have to do that. For example, if the patient is in ICU and non-responsive, or if they are on the floor and non-responsive. At times you are forced to do the x-ray with the patient completely supine, but this is not ideal. On this one, in order to be perpendicular to the sternum, it means that the central ray, the tube head assembly, will have to be angled, because you can see that this gentleman is not sitting straight up 90 degrees and he's not lying flat at 0 degrees. He's in between the two. So you have to make sure that the tube head is matching the angle of the sternum so that the central ray ends up being perpendicular to the sternum. Okay, and again, hard to read these words up here, but this says that this is done very often. There are quite a number of times that your patient might not be able to stand, so you try to get them as upright as you can, even if it ends up being in their bed in their room and you're doing it portably, or you end up putting the head of the stretcher up and having the patient sit up as high as they can. And I know we've talked before that typically T7 falls about nipple line. When you're doing it from the front like this, remember you're going to use jugular notch as your guide. And we said that typically it's 3 to 4 inches down from the jugular notch. But we also said on younger patients, it tends to be more like 4 to 5 inches below jugular notch. So assuming wherever jugular notch is, you would be 4 to 5 inches below that for this gentleman since he is younger. And with this one, they're not all the way down. The reason they're probably not as low is probably because the lungs are not going to expand as much, but if I were doing this, I would still think the central ray would be slightly lower than where they're showing you now. Okay, so central ray is always to T7, and you want your central ray perpendicular to the sternum. This is as a last resort. We do have to do this sometimes, but this is done quite often on patients in the emergency room or in the hospital. When we do this semi-erect, when we look at the image after the fact, and again done on second full inspiration, so we are going to use a 14x17, and you're going to place the image receptor in accordance with the patient's body habitus. Now this gentleman appears to be, I would say, hypostenic, which means that his lungs are more likely to be long versus wide. I would anticipate placing the IR 14x17 lengthwise on this one. Okay. Once you place the IR lengthwise, you're going to place left marker on there. You're going to center to the level of T7, and we discussed having to use the jugular notch and going probably 4 to 5 inches down from that. You're going to have the patient take in a deep breath, then he'll blow that breath all out. He'll take in a second deep breath and hold it. And on that second deep breath, when he holds it, that's when you make the exposure. When that image comes out, this is evaluating an AP semi-erect chest, and they tell you that it's very similar to the PA chest, except that the heart may appear larger because it's AP versus PA. Air fluid levels will not be well defined as if the patient was standing up. And frequently they are not going to get a complete inspiration. You'll typically only get 8 to 9 ribs on this versus the 10 that we like above the diaphragm. But that actually is a pretty decent AP semi-erect chest. Okay, and that picture on page 96 of the AP supine chest, it would look similar to that. Again, the heart would probably appear even larger, and you definitely will not have air fluid levels well defined. Excuse me. So the semi-erect done quite often, the AP supine not as often. All right, now we will look at the next set of specialty views, and these are considered decubitus views. Okay, now on a decubitus view, decubitus implies that there is a horizontal beam. Okay, and when there is a horizontal beam, what happens is the beam is coming in horizontal, and typically the patient is lying down in some position, because typically the reason you have a horizontal beam is that you're trying to demonstrate air fluid levels. All right, so this view demonstrates air fluid levels, definitely. Decubitus does imply that it is a horizontal beam. And in the field, we actually do both lateral decubitus views. So in this particular picture, they're showing him in a left lateral decubitus, and he's facing out, he's facing anterior. We would then, after we made this exposure, roll him towards the chessboard and have him facing it where he would be PA to us, and we would do the right lateral decube. So when it says one is AP, the other is PA, meaning he's facing out in this one, and when he rolled onto his other side, he would actually be facing the board so that we would see his back. But you always do both chest decubitus views in the field. Notice they say that they have a support under his lower chest, meaning you have to build up the bottom of the chest because you can't just clip that anatomy. You have to include both entire lung fields, so you sometimes have to build up this bottom part so that you don't clip it off. Typically, you want to leave the patient on their side a minimum of 5 minutes to allow the air to rise and the fluid to fall. Okay, 5 minutes minimum. If they could lie on their side a little bit longer, that would probably be ideal, but 5 minutes is a good midway point to where things will still layer out and show you what you need to. The technique on this is 125 kVp at 1.3 mass, and you do have to mark the side up with an arrow or a decubitus marker. So notice he's in a left lateral decubitus, but they're using a right marker and an arrow to indicate the right side is up. The reason you mark the side up is because you're not as likely to obscure any anatomy when you have the marker up here. If you were to put the marker on the bottom of the chessboard, it's likely that you'll end up in the lung field. So on decubitus views, we always mark side up, and you tend to use either a decubitus marker or an arrow marker is acceptable, but you will always mark side up. But the position is called by the side that is down. So this is his left side. So he is in a left lateral decubitus with the right marker and an arrow. Okay. Central ray is to T7, just like it is for all chest x-rays, and that is probably found on this gentleman 4 to 5 inches below jugular notch because of his age. All right, we would have the patient take in 2 full inspirations, and we would make the exposure on the second full inhalation. Okay, and that is a left lateral decubitus. As far as what the image would look like, again, you have to include both lungs. So when he was on his left side and we've got the right marker and an arrow, it just means you have to place something under the left side of the chest so that you don't clip this anatomy. Okay, there's no rotation on this. The arms are not superimposed over the lungs, which is good. They did do a fairly full inspiration. There's no motion, and the technical factors look appropriate: sufficient brightness, sufficient contrast, resolution, and minimal distortion. And again, the technique on that was 125 kVp at 1.3 mass. And when we look at decubitus views, realize that air rises and fluid falls. So if you look right here, this is actually fluid in the left lung. You can see air. Let me try and outline that for you a little bit. So right here, this line right here is actually all of this is fluid in the left lung. So I'll get rid of that so you can see it again. So you've got fluid in the left lung, so you can see the fluid line, and then the dark is the air. So air rises, fluid falls. So this patient likely has pleural effusion or something going on. You can see there's all air on this side, but when they roll and do the right lateral decubitus, it is possible you might visualize fluid in that lung. But this definitely is a fluid level in this left lung, beginning, whoops, on the text box, beginning right here. Okay, so you can kind of make that outline out right there. All of this below here is fluid. Okay, and then you can see air above that. You've got air up here, fluid here. So it shows air fluid levels when we do decubitus views. When I was telling you that one is AP and one is PA, this is all I mean. Now, granted, different patients, but she is actually lying in a left lateral decubitus view. Now, granted, you can see this is of her abdomen, but the point is that she's still facing us. So this one is AP, and then when you roll and they're on their right side, now their back is to you. So this one is AP, one is PA. And it doesn't matter which is which, just know that one they will be facing you, one they will face away from you, because all decubes are called by what side is down. So this is a left lateral decubitus abdomen. This is a right lateral decubitus chest x-ray. Okay, so I only threw that in there so that you could see with her facing you versus their back to you. So on one of them, when you were going to do the chest, you would use jugular notch as your guide, and then when they're away from you, you would likely use the inferior angle of the scapula when they're facing away from you, right? And that is a decubitus position. Remember, decubitus always implies horizontal beam, and it's done to demonstrate air fluid levels. The next specialty view we have is called an AP lordotic view, and that is on page 98. And this AP lordotic, the central ray, the it's a horizontal beam with the central ray is directed to the mid-sternum. All right, so it says this view is done to demonstrate calcifications or masses underneath the clavicles. So you're doing this to rule out any calcifications or masses below the clavicles, because what this image does is actually projects the clavicles up off of the chest cavity. So it throws them up above the apices of the lungs so that you're able to visualize underneath in that area and see if there is any pathology going on. The technique on this would be 125 at 2 Mass. And your IR placement would be however it would be if you were going to do an AP chest, whether it is lengthwise or crosswise. With this particular gentleman in the picture, I would guess they did him lengthwise. If you notice under the part or patient position, it says that you have the patient stand about a foot away from the chest board, and they lean back with their shoulders, neck, and the back of their head resting against the chest board. So you can see that his back is slightly arched right in here, and that's because his feet are actually out away from the chest board, and he's leaning back into that. Now, why does he do that? That so that when this image is taken, that the clavicles will actually project higher up off of the chest. Okay, so his clavicles are right here, and this view will actually cause them to project higher and off of the apices of the lung. The central ray is still mid-sternum, which is likely T7 because it's about 3 to 4 inches below the jugular notch. You have the patient taking a breath, then they blow it all out, and they take in a second full deep breath and hold it. Okay, and this, like I said, demonstrates the area underneath the clavicles for any masses or calcifications. So the image would actually come out looking like this, where you can see the clavicles right here, and they are projected above the apex of each lung. So you've got the apex of the right lung, apex of the left lung, and clavicles are above both. You can see air-filled trachea here. They did not clip the costophrenic angles, which is important, and the clavicles are up out of the way. There's no rotation. You can tell that the clavicles are equidistant from the center. There's no motion, and that actually is really good exposure factors. And we used 125 kVp at 2 Mass on this particular image. Okay. They do show an alternative on that same page with the patient lying down and the central ray angled in order to complete the same concept of throwing the clavicles up. But I would tell you that this semi-axial lordotic is probably, I'm just being honest with you, in 30 years of x-ray as being a tech, I've never done it this way. I've only ever done the patient standing up. Okay, much easier on the patient, and typically with whatever's going on with the patient, they're probably able to stand. I'm not saying that you cannot do it with them lying down. You most likely can. I just find it would be a little bit more challenging, and you have to angle the central ray 15 to 20 degrees cephalic or towards the head, and you still come in at the same place. Mid-sternum, about 3 to 4 inches below jugular notch. Have the patient take in 2 full deep breaths and hold on the second breath and make the exposure. And again, the whole point of this is throw the clavicles up off the apex of the lungs so that you can demonstrate any pathology or masses or calcifications underneath that area. And the last of the specialty views that they discuss are the obliques. Okay, and these obliques start on page 99, and they start off looking at anterior obliques. Okay, now any oblique, I would tell you that the radiologist has requested these obliques based on their findings. Okay, so a lot of times they'll describe to you what they're looking at or where they're actually looking, and they will usually tell you to do AO or PO obliques. And they'll typically tell you that they either want shallow obliques or steep obliques. what that's actually referencing is the angulation between the patient and the wall bucky or chessboard. If it's steep, it means they're farther away from the chessboard, and if they're shallow obliques, it means they're closer to the chessboard. So a lot of times I would encourage you to read the report for the information and see what exactly the radiologist is looking at, what they're looking for. The technique on these is 125 kVp at 1.3 mass. And they show you that on the anterior obliques, the side of interest is typically the side farthest from the image receptor. So whatever side is farthest away tends to be elongated and easier to visualize. So in this particular picture, the gentleman is in an RAO, meaning his right anterior surface is closest to the IR. So he's in an RAO, and this would best demonstrate his left lung. If he was turned the opposite way, which I'll show you in just a minute, it would demonstrate the right lung much better. Okay, so anterior obliques means that whatever the radiologist is looking at, it's more likely that it's anterior in the chest cavity, and those would demonstrate whatever he or she needs to see better than if you did PO obliques. All right, so when we look at this next one, you can see this is a 45-degree RAO. This is a 45-degree LAO. Now, what do I mean by 45? If he was flat against the chessboard, it would be 0 degrees and he would be PA. If he was 90 degrees to the chessboard, he would be in a left lateral. So between 0 and 90, you have all different degrees. So halfway between PA and lateral, you have a 45-degree oblique. So this gentleman is in a 45-degree. Left anterior is closest to the IR, so he's in a 45-degree LAO, and this would actually demonstrate the right lung better. And when he's in a 45-degree RAO, it demonstrates the left lung better. Okay, so that is important to know and to be able to visualize that when you're reading the reports. So when we look at the evaluation criteria on here, this is an RAO, this is the LAO. Notice that both images, you need to have the entire lung included. So this one is a little bit close actually on this right lung. That's a little bit close for comfort where they clip that right costophrenic angle. All right, so when we look at that, you need all the lungs included. You need optimal exposure factors, and you need the correct side of the thorax elongated. So on an RAO, you're demonstrating the left lung better. See, if I was to outline for you the left lung, you're talking about all of this. Okay, versus the right lung, you can pretty much make out right there. So much more of the left lung is demonstrated versus the right lung. Okay, and on this LAO, you can see right here, they're demonstrating the right lung. All of this is the right lung, and then this is the left lung. So you're demonstrating the lung farthest from the image receptor or farthest away from the board for AO obliques. The posterior obliques actually are shown on page 101. Okay, and as far as being based on the radiologist's finding or request, that is actually the case. Again, they could be shallow or steep. You want to read the report for the information. We're going to use 125 kVp at 1.3 mass. And when we do the posterior obliques, the side of interest is typically the side closest to the IR. So in this particular picture, he's in a 45-degree LPO because his left posterior aspect of his body is actually closest to the IR. And in this 45-degree LPO, they would be demonstrating the left lung. And if he was in a 45-degree RPO, we'd be looking at the right lung. So on anterior obliques, it's the side farthest that we're looking at. And on posterior obliques, it's the side closest that we're looking at. So when we look at this particular one and they show you which side of the thorax is elongated with the oblique, so in this 45-degree RPO, you can see that between the chest board and here, this is actually what measures from here, from the middle of him to the chest board. This is where you have your 45-degree angulation. Okay, from there to there, on this particular image, this would be an RPO, so you're demonstrating right lung. And on this LPO, 45-degree LPO, you would be demonstrating the left lung better. So let's look at these radiographs. So on the LPO, you're demonstrating left lung. Okay, so when we look at that, again, if you look at just what's in the lung, you're talking about all of this. Right, that's the one you're demonstrating. And on the right, on the RPO, you're demonstrating all of this. Okay, so on POs, it's the side closest. AOs, it's the side farthest away. And you want to always make sure you have the correct side of the thorax elongated. Both lungs have to be demonstrated. No motion and optimal exposure factors. Again, you're reading the report to see what the radiologist is looking for. And realize that sometimes when we do these oblique positions, we can actually use different sets of markers that actually can pinpoint or show the calcification or mass that we're actually looking at. And they're actually called nipple markers. And I will show you a picture of those, but it's basically like a little BB on a piece of tape. And sometimes if we can feel a mass or a nodule, or we know that's what the radiologist is looking at, sometimes we'll actually put that BB on there so that it'll show radiographically, because it is made of metal, and we'd be able to correlate on the skin where that is in the body. Okay, so sometimes we do use those little markers to kind of show where it correlates to in the body of what we're actually looking at. Sometimes too, as people age, especially men, their nipples will calcify, and sometimes on a chest x-ray they can actually read the calcified nipples as a potential for cancer or some kind of mass, and they'll request follow-up views. Sometimes they'll suggest that they do obliques with nipple markers, and you would literally use those little stickies and stick them on the patient's nipples, and then make the radiograph, make the exposure. And if the calcification lines up with where the marker is, then you know that's exactly what that is. But if the calcification and the markers do not line up, then you know that that is not what you are visualizing on that radiograph. Okay? All right, so again, POs demonstrate the side closest, AOs demonstrate the side farthest from the image receptor. When we go through this in live, I do have some images that we're going to put up and actually critique together so that we can make sure that you are understanding what you're looking at. There is quite a lot of information to be visualized on a chest x-ray, and I will tell you that chest x-ray is the most commonly ordered exam. I would argue that that is probably about 80% of what we do in any given day is chest x-rays. They do chest x-rays sometimes just as a baseline for evaluation. They do it anytime the patient comes in having any kind of shortness of breath or any issues with breathing, any kind of chest pain. They do pre-op chest x-rays. They do, realistically, you can get a chest x-ray for just about anything, and it is hands down the most commonly ordered exam. That would be followed by abdomen images. So just know that you will probably do a bazillion chest x-rays in your lifetime. The reason So not only the most common ordered exam, it's also the most repeated exam because every patient is different. Their body habitus is different. So it's definitely one of the most repeated exams out there. All right, well, that takes care of the last half of chapter 2. So if you have any questions or comments or concerns, be sure to write those down, and hopefully I can help clear that up next time we meet. Thank you so much.